not as the sole treatment usually, but as part of it. These are fairly common because people don't eat very well. Even though we have an abundance of food in this country, there still is a lot of people who don't eat well, or don't have the means to eat well, or choose not to eat well. Or with the I shouldn't say fad diets, but people who choose to be vegans and are strict vegans are going to have trouble in some of these areas with iron particularly and B12. So we'll touch those as we go through. All right. And the good thing is that most of this treatment is inexpensive. It's cheap. Okay, so let's start with the iron. We're going to talk about adults and then we're going to talk about children. And really the only time we'll focus on children in this topic is with the iron. Folic acid and B12 don't tend to be as much of a problem with the children. So iron deficiency anemia, pretty common. It's one of the most common of the anemias, especially in children. It'll be the most common nutritional deficiency you will see in children. So some things going down, goals for it, just a little bit down that page. So the goals are going to be threefold. One is, as usually by the time you start to see an anemia develop, it's fairly advanced. So you got to run through a lot of stores before that happens, and the body will continue to provide iron for new red blood cell making. Plus the body will recycle. Body's pretty good at recycling the hemoglobin of old cells, and that will result in being able to reuse that for new cells. So by the time you see a drop in hemoglobin, there's usually a significant deficit in stores, and the ability to turn over and maintain that is you've exhausted pretty much the body's ability to do that. So we want to replenish the stores, we're going to improve the symptoms. Now that is, I'm talking about more chronic. When you've got somebody who has an acute blood loss and they are acutely ill, that's a different situation. You've got to rapidly replace. But most of the time you're going to see chronic, the result of a chronic deficiency. And then treating the underlying cause, always looking for a cause. As long as people are eating an adequate diet, they shouldn't you shouldn't be seeing these. It's when you're doing an extreme of diet that is ignoring these nutrients, you need to be looking at why else. Is there a malignancy? That would be common. Is there an ongoing blood loss? If you've got somebody on anti-platelets or therapy, or somebody who's chronically taking like NSAIDs that tend to upset the stomach and you get a chronic blood loss with them. Same with prednisone. Chronically taking it can lead to blood loss. People on warfarin or any of the other anticoagulants can lead to just chronic blood loss. I'm just giving you examples. I'm not going to test you on those. I'm just trying to give you some scenarios where just a chronic, small amount, 5 mils of blood lost a day, is sometimes estimated with the NSAIDs, 5 to 7 mils a day. Can add up if you are elderly, not taking things, you're not eating maybe as well, can occur over long periods of time. Indications are going to be to treat the anemia, but you could also, which would be common sense, but also would be to see the indices are low, maybe their hemoglobin hematocrit are normal, but their ferritin levels are low. So you know that their stores are low, you may just want to be replacing that to buffer against the occurrence of an iron deficiency anemia. Okay, so in terms of treatment, it's diet and replacement, iron replacement. Most of the time we do oral, but we can do parenteral. I didn't add that under there, but we can certainly get them IV. But usually we'll choose the oral route. So in terms of dietary supplementation, so diet sources are listed there. So the body is amazing. I'm sure you all talked about this, but it's just amazing in its ability to regulate iron. The body doesn't want iron overload, so there's very few situations where that occurs. So the body's really good. If you are iron deficient, then the body will extract more iron out of your diet. And if you have good stores, it's only going to replace what you're losing, which is a small amount every day. So the body's really good at regulating iron intake. So most of what you eat, the iron out of that won't ever be used or absorbed. You'll just excrete it in your stool. But the foods that are good in iron are those that are listed there, the meats, fish, poultry, usually poorly absorbed from vegetables and grains, except for the iron-fortified cereals and oatmeal. Dairy products, eggs, not as good absorbed from there. Orange juice seems to be one of those exceptions, really good at promoting iron absorption. We'll even recommend it when we get down to having maybe some orange juice, or people taking iron with orange juice to increase absorption. Note that teas, coffees, those tend to decrease because of the tannins and the other ingredients in the coffee. It's not the caffeine's the problem. Can also reduce iron. Anything to add?
That's right. The tannins will bind to the iron, so you just excrete it and don't absorb it. And the most common I would see that with would be milk.
Yes.
People would, especially kids, giving milk with meals, you're not really going to absorb any of the iron that the kids are getting. So children's, you'd see a ton of kids with iron deficiency related to excessive milk consumption.
Very good point. And the other is that people will tend to use milk to buffer their stomach when they take medicine. So that's a good one to always point out, even to adults, is if you're taking iron and you've got to have something on your stomach, don't take it with milk if you can avoid it. It'll complex the calcium and it will complex the iron. That's what we'll see mostly with iron or the problems is either substances will complex it and cause it to precipitate out, and then it can't get absorbed, or you'll have a binding of it, and then you also, it just won't be available to be absorbed. Okay. So moving down to oral iron therapy. Luckily, iron is very inexpensive. It can be purchased over the counter. It's available in tablets and in liquid forms. One thing to note is that because it is so upsetting to the stomach and it causes a lot of constipation, then people may look for or use a slow release iron. And we used to do this years ago. We used slow release iron preparations because it bypassed the stomach and got it into the intestines, where it wasn't so upsetting to the stomach. But what we found is that if you do that and you get it into an alkaline environment like you have in the intestines, and what happens is that the iron just precipitates out and you don't get absorption. So we recommend now that people don't use the extended release or the slow release iron products anymore. So the soluble iron is the ferrous, not the ferric. So we don't use, you will find very few products that are ferric salts or form of iron. So almost all of them are going to be ferrous, and that's what we want. There are lots of salts. So you see those on the bottom of page 2. Sulfate will be the most common, and it has the most available, or one of the most available of the iron, elemental iron. So there's sulfate, succinate, lactate, fumarate, glutamate, gluconate. The three most common are the sulfate, the fumarate, and the gluconate. And you'll see that in the table that follows. When we talk about iron and we talk about dose, we talk about elemental iron. So as a rule, when you get a strength of a medicine, it's that strength is including the base. Okay, it's the base and the salt. If the strength is only the active substance, it will tell you that it's base. It'll usually use that term. So that just goes for almost all medicines. So know that when you've got a prescription items that's 500 milligrams, it may only be 50 milligrams of active substance because they're telling you the weight of the product that they're giving you. Okay, so all those things that we put into a tablet, there's fillers, there's binders, There's other excipients that have no activity. They're there just to keep the dosage form in an intact form in order to get it wherever you want it to go, in the gut, okay? So, we'll see this with calcium when we talk about calcium supplements as well. So if you look at that table that's down at least for me it's page 3, elemental calcium is really important. So for those 3 salts, you should know those. So when ferrous sulfate, whatever dosage strength you're using, 20% of it is elemental iron. So when you prescribe it and you know the amount you want, which in here we talk about 150 to 200 milligrams of elemental iron a day is what you need for replacement. That's the elemental, it's not the salt form, okay? So if you see that, the ferrous fumarate, ferrous sulfate, if fumarate has the most, it's 33%. Sulfate's 20%, gluconate is 11%. A lot of people like gluconate because it has less elemental iron, so it upsets their stomach less. So that you'll find that people may gravitate to that. Well, I like this one better, it doesn't upset my stomach. Well, that's why, it's less iron. Okay. There are more and more liquid products. A lot of people prefer, or some people prefer liquid, and I've done this myself with folks, is because I can titrate. If I have people who are really anemic and they cannot, they'll refuse parenteral iron, or maybe they're just not a candidate for it. If you use a small amount of iron, I'll usually have them dissolve it in water and drink it. Then I can slowly titrate, and they seem to kind of build a GI tolerance to that iron over time. So that's a lot of that. That is one trick you can use. Be aware though, the liquid iron preps are usually more expensive, especially when you're looking at that Novoferrum. It's fairly expensive. I do not expect you to know those elemental iron on those liquid preps, but you should know that liquid is available, and you should understand the elemental iron concept. But for the salt forms, those 3 salt forms, because they're the most common, I want you to know the percent of elemental iron for those salts. I don't care if you know the dosage strength that comes in, but you need to know the percent of elemental iron. Okay, questions about that?
Would we have a calculation one in the exam?
Oh, you might. I might say here's the dosage form. How much are you going to have to give? Or you got the patients taking this much, how much are they getting?
Is there any validity to taking a gummy over, like a multivitamin gummy over a solid as far as not upsetting the stomach as much?
I haven't seen any of that. I don't know. I didn't see anything in the kids' literature, but I didn't look that much for it.
I know in labor and delivery a lot of our OB-GYNs would recommend it for moms taking prenatals. But I could never seem to find why that would work, but they would report that there would be less GI upset whenever they would do a gummy.
Yeah,
I don't know why, it doesn't make any sense to me. But
I don't know. I didn't see anything, and I didn't choose to look at the gummies.
I think they just like to eat gummies. That's my personal.
It may be yes, it may seem like a kinder way to eat something that looks like a bear than a tablet.
Okay, that's curious.
Talked about all that. Okay. Let's go down to dosing and administration. So the amount of iron that somebody's going to need is going to depend on age. So we'll see with children that the age requirement or the dose requirement's a little bit different. What the iron deficit is estimated to be, how severe or how far down are their ferritin losses. How fast do you need to correct it? If you have to do it fast, you're not going to use oral. Okay, you'll either transfuse them or you will use a parenteral iron, which can restore iron amounts very quickly. And then how the side effects are going to square up with what else they've got going on. If they already have GI diseases that they're dealing with, it makes it a lot harder. You may have to go to a parenteral iron as opposed to an oral iron because they're just not going to be able to tolerate it. So if somebody had Crohn's or ulcerative colitis, may not be able to tolerate it as well. Let's see. So we're ferrous salt, always we're going to use it. The recommended dose is 150 to 200 milligrams of elemental iron a day. We always divide it up if we're going to give more than, to give that amount. The one thing about, the reason why, one is it's easier on the stomach, but the other is that when you give large doses of iron, less gets absorbed. So the smaller amounts that you give, the higher percent of iron will be absorbed. Now if you give a higher dose, you'll get more absorbed, but it'll be a lower percentage. So that's another reason to divide the iron up throughout the day. So a typical prescription for an adult would be ferrous sulfate, 325 milligrams 3 times a day. We would like them to take that on an empty stomach. That's what we'd like for them to try to do. When you take it with food, it reduces the amount of iron that's absorbed. So if we can get them to take it at least an hour before they eat, in between meals, that gives you the best absorption possibility. Older adults, you may have to start with a lower dose and titrate it up. I read all kinds of approaches that people are taking. I'm not going to test you on these, I'm just telling what's out there. So people are looking at once a day, every other day, once a week, to see if they can get at least the replacement in there without upsetting the stomach. The number one reason why iron therapy or replacement fails is that people won't take it. So non-adherence, always. When I see people on iron, I always assume they are not taking it like it's prescribed. Like for 3 times a day, hard to do. Really is constipating, especially in older folks. And so they're going to avoid it. So starting there and working, either titrating up smaller amounts, depending on how fast you have to go, keep those in mind. I cannot emphasize enough is that iron has to be kept in a childproof container, has to be put somewhere where a child or a pet cannot get into it. Iron overdose is lethal, and it is a terrible way to die. It is so painful, and a lot of times people don't figure it out until it's fairly far advanced. A lot of iron tablets in the past used to look like candy, and so they look like, what do you call it, Good and Plenty. It's an old candy. But it is one that children can confuse with candy. I've even seen it in older people where they will confuse those tablets with a candy product. So iron got to be stored. So when you're talking to moms and they've got little kids at home, keeping that stuff out of their way or out of any way that they can get it is important. Pets, the same thing. Had a dog one time that chewed up an entire bottle of acetaminophen. I have no idea. I can't imagine why it tasted good to her or why they cared, but keeping it out, pets, it's the same thing. They're small, and so the lethal amount is not going to be very, very much. Okay, we talked about some of these. I just keep repeating the same things over and over in other sections to just emphasize the points. So the ability of a person to tolerate an oral iron replacement is the major determinant of the replacement dose. So you can either start low and go slow, or you can start with the dose and see how people tolerate it. Okay, let's look at bioavailability and absorption of iron. Lots of things change the absorption, lots of things will change the bioavailability. So separating it from calcium-containing foods, calcium-containing antacids. That would include like Tums. So a lot of women take Tums as a calcium replacement, not so much for antacid. So that would be a problem in taking those together. Some people, because of the stomach upset, they may not, or in the beginning, associate, I've taken this drug and now my stomach is upset. So they may start taking over-the-counter products like that will decrease their stomach upset, like, or their GERD. So, or if they're already taking something like an H2 antagonist, so that would be like ranitidine, famotidine. Are those products you're familiar with? Zantac, the brand names, they don't use them anymore. So if you go in and you want to, if you were going to choose something for an upset stomach, what would you all take? Huh?
Pepto-Bismol.
Oh, Pepto-Bismol, okay. What else would you do?
Tums.
Tums, okay. So omeprazole, the proton pump inhibitors are over the counter, that's Prilosec, the purple pill or the purple capsule, they'll call it. That decreases stomach acid. Anything that will suppress stomach acid is going to interfere with the ability of the body to absorb that iron. Okay. So iron does better and gets absorbed better if you've got a mildly acidic environment. Okay. So we don't, if we get full suppression of stomach acid, we're going to get less absorbed. Okay, so tea, coffee, we've talked about. Vitamin C can be used either in orange juice, or vitamin C tablets can also be used, taken with iron. You will find products, because the manufacturers know this, you'll find iron products that have vitamin C with them. Or you'll find over-the-counter products that have stool softeners with them. Most of the time, I'll tell you that there is not enough of either one of those with an iron combination product to solve the problem. So, and they're usually going to be more expensive. So if you're wanting more absorption, have them take it with orange juice or just use vitamin C tablets. Okay. If they're really having constipation, well, you can work on that through other means. You can use the stool softener, but you'll have to use higher doses and a lot of water to get that effect.
Dr. Latassi, if they are taking something for stomach upset, like Tums or Pepto-Bismol or whatnot, should we tell them to stop taking that, or is there an order they can take it in where it minimizes?
Yeah, there's an order. I put it in here. I think it's 2 hours after an antacid and 4 hours before the next dose. But it becomes a complicated mess is what it becomes. It gets really hard. If you've got somebody who's got that much stomach problem or underlying where they need a lot of treatment, you've got an ulcer you're dealing with, you've got an esophagitis, probably a parenteral iron therapy is going to be better. Okay. Under adverse reactions, so you've got it. GI is number one, most common complaint. The other things to warn them is that it will turn their stools dark, a black. They could become tarry. Tarry always is worrisome because we think blood. We think lower, or in the GI tract, we think there's been a blood loss. But warn them that this is definitely a possibility. Anything that's GI possible usually can occur with iron. Nausea, vomiting, diarrhea, constipation, increased gas production, all of those, metallic taste in their mouth with when they eat. And they're dose related, so the higher the dose you're going, the more likely these are going to happen. So that's why it often works to start with a very low dose through a liquid and titrate it up. Let's look at the drug interactions. We've mentioned some of these already. Any antacid will bind it. Aluminum, magnesium, calcium, any of those will bind. So separate them out. And usually here we're talking about when people are just doing it on episodic. Or warn them. If you're having stomach upset, okay, you can treat it, but call me. Let me know if it's going to start interfering with your ability to take the drug. two antibiotics that are a class, the tetracyclines, doxycycline will bind the iron, so separating those out. So people take those chronically for acne would be one. Showing them how to separate those out would be important. The H2 antagonists and the proton pump inhibitors, again, suppress the acid, decrease absorption. Another drug, cholestyramine, Questran is the brand. We use it some for treating cholesterol, not very much anymore. But it's also used if people have itching from many different reasons. Often it is related to liver disease. They'll use that Questran to bind bile acids, which have been implicated in that pruritus. So those binders can then bind the iron as well and cause them not to be absorbed. Okay, duration of therapy, it differs among it differs among what you're doing and what the reason or underlying cause. If there's an underlying cause and you can treat that and that's going to stop the iron loss, then the treatment duration may not be very long. But if you're dealing with a chronic iron deficiency anemia, then usually 6 months is about what people are going to be looking at. In terms of, if we look down a few bullets, the 6 to 8 weeks will bring that hemoglobin and hematocrit back up, but to get iron stores restored, it's going to take about 3 to 6 months. So that's why you see that recommendation for 6 months. Okay, so monitoring parameters. So 3 things you're going to follow. One would be reticulocyte counts. So if you're giving the body iron and it can make, and it's got already got an anemia in place, the first thing you're going to see is those retic counts are going to go up, and they should go up in the first week or so. Then your hemoglobin and hematocrit are going to respond. They're going to take a little bit longer though to respond. Red blood cell counts are going to go up. Your mean cell hemoglobin is going to increase. So you should see a slow rise within 1 to 2 weeks. In about a month, you're going to see at least a 1 to 2 gram per deciliter increase in that hemoglobin. Retic counts, usually that's a good sign. But with a note that if you're just replacing stores, then you may not see a retic count because they're able to make red blood cells. There's probably no oxygen delivery problems, so the body is not going to put out more red blood cells. So moderate to severe, you're going to look for that retic count. If you've got a moderate to severe and they're not increasing in the retic count's not going up, then you need to look for other causes. Maybe they're not taking it. Maybe there's another ongoing problem that has not been addressed that's also adding to it. And then we're going to also look for symptom response and ferritin body stores to go up. That's going to be your late. So retics your early, hemoglobin hematocrit's in the middle, and then ferritin is your last to respond. Reasons for failure, almost always, not almost always, most common, they're not taking it. Okay? So always going there first. So malabsorption can be due, since you're going to see more and more people who've had gastric bypass, this is a problem area. Some is that the amount of pills. One thing I work with gastric bypass patients is what do you do with that pill burden post-gastrectomy or post-bypass? So sometimes it's just they don't take it because they just can't take that much down as part of it, and then the other is they can't absorb it. So looking for or celiac disease or other diseases that would where malabsorption would be part of it. Blood loss is equal to the rate of production. So that could be in somebody who's on chronic warfarin or anticoagulation therapy. They're just losing enough all the time that doesn't make them necessarily symptomatic, but you can't get ahead of it. or you've got another coexisting cause, something else is causing the anemia. There's an underlying cancer that hasn't been diagnosed, perhaps, or an autoimmune disease that's not well controlled, rheumatoid arthritis maybe, lupus. Strategies to improve tolerability, we've talked about a lot of these already. One is you can switch the formulation. If you have them on ferrous sulfate, you could go down to ferrous gluconate. So that could help going to the liquid, titrating up. We talked about, or parenteral iron. So the thing mostly I want you to remember about the parenteral iron is that it's an option. You will probably refer it to someone because it needs to be monitored, has to be given IV. Usually it's given over about an hour's period of time, has to be done multiple times. So knowing that it's an option and when to refer, I think are for you all the most, unless you're in an office where that's something you do, or a situation where you work with a hematologist or an oncologist, you may be doing that on a regular basis. Questions about the oral iron therapy?
Yeah, for the increase in bioavailability with orange juice, are you specifically increasing the elemental iron? So for example, if you give 325.
You're keeping it from precipitating out as much. So as it moves into the intestines, you just got a little bit more available. It isn't so much that you're reducing that state from ferric to ferrous, because you're giving a ferrous salt. So it's more keeping it in a soluble form so that you can get more absorbed.
So, but you still, because if they can get toxic on this, then you want to know that you're not, if you're giving 325, they're not going above 20 elemental.
Right. Yes. Yes. You're mostly keeping it in a soluble form, not precipitating and maybe binding with other things that are in the diet. Would be it. Where you may run into problems with the orange juice is when you're getting you're working with patients with diabetes who often have concomitant anemias of chronic disease. You may want them to avoid the orange juice. So that's where the vitamin C tablets may be more reasonable. It's not going to raise their blood sugar as much. On the parenteral iron, I want you to know those indications. Yes?
Do you get more absorption with liquid iron than with just a tablet, or is that just solely like to titrate up?
But I don't know. I didn't look at absorption rates, so I don't know percent of but I don't know if it changes bioavailability or not. Indications, I think you should know those because I think those are going to be the things that you, in your practice that you're going to go, okay, it's time to move on to something else. So those would be an intolerance. You've tried all your tricks and you just cannot get them to take enough of it. You also may want to do it with people who are fairly non-adherent in other respects. It may be that doing the parenteral iron, you know that you could get their iron stores back up and you're not going to have to worry so much about other circumstances that are going to prevent them from maybe accessing or keeping in contact with care. So you may be sitting there and going, well, why don't we just give everybody IV? Well, the problem is that it's tricky to give, it's more expensive. You have to be monitored, it has to be, you got to have an IV access. And hypersensitivity reactions are high. Anaphylaxis is a real problem with parenteral iron. There are 4 products now that are on the market. You do not have to know those. But you should know, let's see, the next page. Dose, you don't have to know because you're not probably going to be doing enough for that to be your concern. It'll be more of whoever is administering it. But I want you to know that it can quickly restore, and it can be done over a few days. Some of those products can be done over 1 or 2 settings for the patient. But anaphylaxis is the big problem. The iron dextran, the old, we used to give IM, probably the most common or drug that cause those hypersensitivity reactions. And I mean, people die. So that's why we've got this, it's great, it's efficient, it's effective, but you got this huge problem in terms of the likelihood of a anaphylactic reaction. Still small, but it can be deadly. So they have to be monitored, they have to have resuscitative equipment nearby if they're going to give parenteral iron. So just going down through those indications, again, a malabsorption syndrome that is maybe not well controlled, or where you know that that's going to be a problem and you need more quickly to replace. Long-term non-adherence. The blood loss exceeds the capacity for the iron to replace it. Refusal to accept a blood transfusion for a significant blood loss. Anemia due to chronic disease, especially those on hemodialysis. You'll see this quite a bit. They have multiple. They'll have problems with folic acid deficiencies as well. Cancer patients who are on ESAs, erythropoiesis stimulating agents, we'll touch on just very briefly at the end, or a coexisting inflammatory state, rheumatoid arthritis, SLE. Often if we can address those and get those under control, get the inflammation related to those under control, then we can also get the anemia to respond to treatment better. All right. Any questions or comments to that point? Okay, let's look at the kiddos then. So kids, if they are infants, we'll talk about them first. If infants are exclusively breastfed, usually by about 4 months, they will need iron supplementation, or their hemoglobin hematocrit will drop. Did you all talk about that with your other providers? Okay. When you get and so a lot of children will be put on iron, if they're on formula, they can use an iron supplemented formula. Sometimes those are not very well tolerated, and they may move up to a lower iron concentration, or a modified cow's milk formula. So those you have to look at how much iron they are able to get from their whatever their feeding source is. Once they move on to cereals, those cereals are usually iron fortified, the infant cereals. And then eventually incorporating pureed meats into the diet of the infant will help with the iron replacement as well, or an iron source in their diet. It's that large intakes of milk that can be a problem. So here the recommendation is limiting it to 20 ounces a day once you get past infancy. Having fruits in the diet would also be helpful in terms of vitamin C. Anything else, Amy? Okay.
I think the infant formulas, now all the formulas are iron fortified because there were so many deficiencies. So just know infant formula is the most confusing thing, I think, because if you go, it's like a medication. There's so many different kinds, and some will say with iron, some will say without. But just know that's there. And then again, watching for milk. That's like the number one thing you would see is my kid won't eat, so I'm giving him milk as a healthy alternative.
Right.
And so the kids, you don't actually catch them until they're failure to thrive, they're stunted, their head's not growing.
Oh,
And
gosh.
that's kind of actually where we would actually see those kids was pretty severe consequences and not just like their H and H is low.
Okay. Never underestimate, well, you know, when I was growing up, you had nutrition classes. Everybody, you knew about food because it was taught through health. But a lot of your moms may not have that understanding or that education. And it may be that socioeconomic situations also limit their ability or what they choose. I have seen children that have gotten to 8 to 10 And there's no fruits or vegetables in the house. They go through and they do fast food. I've had children that have never seen a fruit, never had them. And I was dealing more with them with diabetes, so we were dealing with usually overweight, usually due to malnutrition. In another sense is that you just don't get a complete diet. So sampling those, I don't know, it seems like when I had a child, the nurse would sit down and ask me all these questions at each of the well baby checks about diet and what we were feeding them. But never assume people know how to eat. So asking those questions is important, especially when you're dealing in situations where you think there may be obstacles to food security. So I think it's 1 in 5 children in this state do not get enough to eat. So the food insecurity in Oklahoma is pretty high. So keep that in mind depending on the source or where you work and who you're dealing with. Okay, let's move on then to the vitamin B12 deficiencies. Usually we see this in older folks, not all the time, but usually it's more manifests itself with age. The goals here are to replace stores, vitamin B stores, which are pretty large. It takes a while to go through those. The hematologic manifestations, the